And so after that, well, with that treatment, that still produces results of less than 15 months of survival. So even still, it's not super effective, the treatment options that we have. And some of the reasons why treatment is so difficult for this type of tumor is that there are several barriers. So one of the barriers is the blood-brain barrier. And what this is it is a semi-permeable membrane in between the blood and the brain, and it helps to prevent toxins from entering the brain. So in general, that's a good thing. But in the case of administering a drug to a tumor in the brain, it makes it very difficult for the drug to reach the tumor site. And then another barrier to treatment is extensive tumor heterogeneity. And so what happens with that is that there are multiple different genetic subtypes of tumor cells within the tumor. And so you can be treating the tumor, it can be responding well to therapy, but then one of the genetic subtypes is not responding to therapy, and then it takes over and the tumor recurs. And then another barrier is glioblastoma-induced immune suppression. And so that's the barrier that we'll focus on today. And so here are some different types of ways that this tumor suppresses the immune system. So it causes these different types of cells to come to the tumor site. So tumor-associated macrophages, myeloid-derived suppressor cells, regulatory T cells. We also have some immune checkpoints, so the CTLA-4 and PD-L1, PD-1 immune checkpoint. And then there's also the production of immunosuppressive molecules within the tumor site. So we've got IL-6, IL-10, TGF-beta. So there's a lot going on here preventing your own body from killing this tumor. But we're going to focus on two of these types of immune suppression today. So myeloid-derived suppressor cells and the PD-L1, PD-1 immune checkpoint. And this is just because we're just focusing on these just because of data that we have associated with this. So to get into what this immune suppression is, what these two forms of immune suppression are. So with PD-L1, PD-1, what happens with that is that T cells go around your body and check to see if different cells are part of your body or if they're foreign. Because if they're foreign, the T cells will kill that cell and do away with it. But if they're part of your body, what happens is that they'll have this PD-L1 receptor on them. And this will bind to the PD-1 receptor on the T cells, forming this complex, and then preventing the T cell from killing that cell. So in general, that's a good thing. You don't want your own body killing itself. But in the case of tumor cells, that's not good. So with tumor cells, they are part of your body, but they've been mutated in order to be rapidly growing now. And so they still have this PD-L1 receptor. And so this complex still forms and it still inhibits the T cells from killing the tumor cell. And so how we can prevent that type of immune suppression is by applying this immunotherapy anti-PD-1. And so anti-PD-1 will bind to the PD-1 receptor on T cells, preventing that complex from forming, and then the T cell can kill the tumor cell. At least we hope, because anti-PD-1 as a monotherapy in GBM actually failed. And so one of the reasons why it failed with this tumor is because there's this added layer of immune suppression. So there are these myeloid-derived suppressor cells. So myeloid-derived meaning from the bone marrow, and then suppressor cells meaning they suppress T cells. And so here in this diagram, we have, so the cells that are labeled with both the red and green fluorescent markers are these MDSCs. And so as you can see, when there is a tumor present, these are present in the brain, and when there's no tumor, these are not present. And so what happens is that the tumor produces these chemokines, so molecules that cause movement. And these chemokines are ligands of a receptor on the MDSCs, the CCR2 receptor. And so as the tumor is producing these chemokines, this chemical gradient forms, causing the MDSCs to travel from the bone marrow up the chemical gradient to the tumor site, where they then suppress the T cells. And so what we can do to prevent that from happening is applying an immunotherapy, so a CCR2 antagonist, and this will disrupt this recruitment and keep the MDSCs away from the tumor site. And so an overview for what we're going to talk about today mathematically is we're going to go over the treatment-free model that we developed, and then experimental data along with that and parameter analysis. And then we're going to extend this model to include combination immunotherapy. And with that, we'll perform optimal control to optimize an immunotherapy regimen for a single patient, and then do treatment personalization for a virtual patient cohort. And so the first part is to identify targets for treatment, and the second is to optimize treatment. So here's a diagram of the interactions that I talked about occurring in GBM. And then here's the model we created. So we've got an ODE model of tumor cells, T cells, and the MDSCs. And so just going through that. So we have the tumor cells modeled logistically in order to have that carrying capacity where the tumor cells aren't growing exponentially. Then they are, as they interact with T cells, they are killed by the T cells. And then for the T cells, we have their activation as well as their stimulation. So when the tumor is present, that stimulates T cells to travel to the tumor site. And then with the T cells there at the tumor site, then those are inhibited by that complex forming. And so this equation is just showing, so this part is showing the number of cells that have PD-L1 on their surface. So both T cells and tumor cells have PD-L1. And then this is just showing the number of cells that have PD-1. They interact, and then their inhibition rate is shown by row. And then with this, here, I'll just move the Zoom screen. Okay. With this, the T cells are inhibited by MDSCs coming to the tumor site. And then they die at a rate of DT. They die naturally. And then for the MDSCs, they're stimulated by the tumor, releasing those chemokines to travel to the tumor site. And then also something I didn't mention earlier was that when a tumor is present, this causes an increase in the proliferation of MDSCs in the spleen. And so we're assuming that that has an effect on the number of these cells that get to the tumor site. And then lastly, they die at naturally at a rate of DM. And so with this, and now we've gone over how the model is developed. And then we'll get into the data. So with the data that we got from our collaborators in the pharmacology lab here at UF, so what they did was they took mice that were genetically modified in order to have the immune cells that we care about fluorescently labeled. And then these mice were then implanted with gliomas. And then after a bit of time, the brain was resected, frozen, sliced into little 2D slivers, put on a microscopic slab, and then put into the fluorescent microscopy machine. And so with this could take those cells that were fluorescently labeled, count them up, and then get us cell count numbers. And then that's done by the cell profiler program, put into an Excel sheet, and we've got our data. So here is an example of what the data looks like. And so here we have an outline of the tumor, and then the cells that are both red and green, those are the MDSCs. These are the T cells. It's harder to see in that image, but that's what the data looks like. So we take that cell count data, and then we want to figure out parameter distributions for our model and that are relevant to the data. And so what we do is we perform the approximate Bayesian computation method. And so what this does is it samples parameters uniformly from the range that we got from literature. And then it runs a numerical simulation with each of those parameter sets. And then we calculate the relative error for each of those sets. And then with sets that are below a specified error threshold, then we take those, and then those form our distributions. And so here is what the output looks like. And so along the diagonal here, we've got the distributions. And then here we have the 5 different parameters. So there are more parameters than this in the model, but it'd be too much to have on this one slide. And then the same 5 parameters are on this side. And so then the areas where it is darker, that shows that more parameters were accepted there in that region. And then we have the relative error in terms of just the glioma cell error, T cell, MDSC, and then added that all up to have total error. And so then taking that diagonal marker there, so that's 1 parameter set, we took that. And here's an example of what the simulation looks like that had the minimal error for the average mouse data. So we have the tumor cells, T cells, and the MDSCs plotted along the average mouse data. So this set will come back, this parameter set will come back into use later on. But now we'll switch to sensitivity analysis. And so what this allows us to do is to determine which parameters have the largest impact on our system when we shift them. And so the method that we used was EFAS, so the Extended Fourier Analysis Sensitivity Test. And what this does is, a nice thing that this does is that it uses the probability distributions for the parameters in sampling them. And so we split, since we had just determined these probability distributions, this factored into our work with EFAS and then made the sensitivity analysis more driven by the data. And so we split the sampling into right skewed sampling and uniform sampling based on the parameters. And then using those parameter samples, then we calculated the variance of the output with respect to each of the parameters. And then what EFAS does is it divides the sensitivity index for each parameter into the first order index and then also the total order index. So what the first order index does is this is when we shift just one parameter, this shows the influence that single parameter by itself has on the model output. What the total order does is it takes that first order into account, but then it also takes into account that single parameter also interacts with other parameters to have a greater influence on the output than it could by itself. And so this shows what that one parameter can do as a whole. So here's a sensitivity analysis for tumor cells, T cells, MDSCs. And then the red is the first order index, the blue, you can expect it to always be larger than the first order index. And so that's there. And so then what we find from this is that the most sensitive parameters for the tumor cells are the tumor growth rate, tumor carrying capacity, and the T cell kill rate. For the T cells, we have T cell kill rate and the inhibition rates by the PD-L1, PD-1 complex and by those MDSCs, so those immunosuppressive cells. And then for the MDSCs, we have the same as the tumor cells along with the MDSC death rate. And so what this helps us to determine is different potential therapeutic targets that clinicians could look into for addressing glioblastoma. So with the tumor growth rate, how we could address that would be through surgical resection or chemotherapy. So chemotherapy specifically targets rapidly dividing cells, so that's why it would address the tumor growth rate. Surgical resection, when you surgically remove a tumor, this disrupts the vasculature, so the blood vessels, and so then this decreases the amount of nutrients that are reaching the tumor site, thus decreasing the tumor growth rate. And then that's also why surgical resection would actually also target tumor carrying capacity, because it would decrease the number of tumor cells that brain environment could support. And then the T cell kill rate, we could address that with immunotherapy to boost the immune response. And then the inhibition rate by PD-L1, PD-1, we could use that one immunotherapy I talked about, anti-PD-1, to address that, or we could use anti-PD-L1, which is addressing the other side of that complex. And then the inhibition rate by MDSCs, to target this, we could use an immunotherapy targeting that specific mechanism. And then the MDSC death rate, we'd use an immunotherapy directly killing MDSCs. So now we've gone over that background with the treatment-free model, and our goal is to now extend it to include those two types of immunotherapies I mentioned, anti-PD-1 and the CCR2 antagonist, and optimized treatment. So to extend it, so in this diagram, you can see we have anti-PD-1 disrupting that complex, and then the CCR2 antagonist preventing the recruitment of MDSCs. And so here we have anti-PD-1 modeled, so 1 minus U1. And what you can consider this is actually a scaling of this inhibition rate parameter. And so something a little bit different about how we're modeling it, just because of limitations with the data on actual anti-PD-1 dosages, and that's their influence on glioblastoma's growth rate. We instead modeled anti-PD-1 as the percent in which it reduces this inhibition rate parameter. So a little bit different than modeling it with dosages. And then for the CCR2 antagonist, we did the exact same thing. So it's a scaling of this recruitment parameter. So it's the percent in which it reduces that parameter. And so now we can use optimal control theory. So the goal of optimal control is to find controls over a period of time that will minimize an objective functional. So in our case, those controls, so those things that we're manipulating, are the amount of anti-PD-1 and the CCR2 antagonist that we are treating a patient with. And then the objective functional, we will construct that to minimize both the tumor burden and the drug toxicity. So what we want to do, what our goal is to apply enough drug that it will decrease the tumor size, but we don't want to apply so much that the patient has toxic effects. And one of the reasons for that is because there are several side effects for these immunotherapies. So anti-PD-1, these side effects are all from clinical trials using anti-PD-1. So patients experience fatigue, rash, nausea, weakness, shortness of breath, constipation, vomiting, headache, and fever. So all of those things we don't want patients experiencing. And then the CCR2 antagonist, by comparison, is relatively safe. There's only one grade 3 adverse event. So grade 3 meaning the patient was hospitalized for it in a clinical trial. And that event was the patient had a rash. So it must have been a pretty bad rash. But aside from that, compared to anti-PD-1, pretty safe. And so now, knowing that, we want to start solving the problem. So the software we're going to use to solve the problem is GPOPS2, and this is a MATLAB software developed by UF for solving nonlinear optimal control problems. So perfect for our situation. And so here, there's a lot on this slide, but here is our problem stated out. So we have, we want to minimize this objective functional. So this objective functional takes into account the tumor, anti-PD-1, and the CCR2 antagonist. And anti-PD-1 and the CCR2 antagonists are just squared for numerical reasons for minimizing this objective functional. And then we have weights in front of the CCR2 or in front of the tumor and anti-PD-1. And so with the tumor and anti-PD-1, we have a 2 in front of that, and that's just because we want to focus on minimizing this over focusing on minimizing the CCR2 antagonist, because this one was more safe. And then with the tumor, we also have it divided by its carrying capacity. And this is just because since anti-PD-1 and the CCR2 antagonists are, in terms of percent, they're bounded above by 1. And so this is just to make sure that this has a similar bound. And so this problem, we also have the treatment time period from day 7 to day 50. That is based on previous experimental regimens with toxicity and with these two drugs in mice. And so actually a lot of these numbers in this slide are based on either directly on the experimental regimens or analyses of these regimens. And so we want to minimize this, and this is subject to our three-equation ODE system we went over. And then for our initial condition, we have 35,000 tumor cells implanted, and then a very small population of T cells, 100 T cells, and then 0 MDSCs. So that's consistent with the data. And then both anti-PD-1 and the CCR2 antagonists are bounded in their individual administrations as well as their cumulative administrations. And that's again just based on those previous experimental regimens. And then lastly, we have that the tumor size at the end of treatment needs to be less than or equal to the tumor size at the start of treatment at day 7. And this is just to ensure if we're not actually going to decrease the tumor size, then we may as well not treat the patient and have them go through that. So here's the optimization for the parameter set of best fit. So this is going back to that simulation that I showed you 10 or so slides ago. And so with this, since that parameter set was based on average mouse data, we assume that this regimen is suitable for the average mouse. And so just some info on how to interpret this. We have tumor cells here, T cells, MDSCs, anti-PD-1, and CCR2 antagonists. And then for each of these graphs, we have, for instance, here, the tumor cell growth before treatment, its growth during treatment, and then after treatment, how it grows, and then the patient dies around this point. And so with this, and then with the two drugs, we have both drugs model in terms of % reduction. And so given that data on GBM response to these two drugs, we would be able to get actual dosage and then the frequency of the dosage. But instead, what we have here is the treatment time period. And so some similarities to other regimens is that the CCR2 antagonist has a longer constant treatment period. And then some differences from the experimental regimens is that for both therapies, treatment starts later but lasts longer. And then for anti-PD-1, this difference is particularly unique. We have a very small initial treatment period and then a bit of a break, and then this longer treatment period at the end. And so usually what we have for anti-PD-1 is just one constant treatment period. But with this regimen, we found that the mouse lives 111 days post-tumor implantation compared to 32 days without treatment. So this greatly increased the mouse's lifespan. And then our next, before I get to that, this optimization was for a single parameter set. But what we want to look into is, okay, if we are looking at a group of mice, technically each of them have their own individual parameter sets. And so technically they could each receive their own personalized, optimized immunotherapy regimen. And so what we want to look into is to figure out which of those mice in this virtual clinical trial would be the most likely to survive or the most likely to die after treatment. And so what we want to look into before we get to that is parameter identifiability analysis. And the reason why we want to do this is we want to consider which parameters should we vary for treatment personalization, because it would be useless to vary parameters that we can't actually identify with data, because then we could generate conclusions for those parameters, but not actually be able to use them in reality, and so it would be pointless. And so what parameter identifiability analysis shows us is what parameters can we uniquely identify with data. And so this analysis is split into two subparts. So we have structural identifiability and practical identifiability. Structural is a more theoretical approach. So this is a best case scenario. And with this, a model is structurally identifiable only based on the model structure and the data type used. So it's not based on the data quality at all. And so the data is assumed to be completely thorough, completely accurate, which is not what we see in reality. And so that's why practical identifiability comes into play. And so this is a real world approach where we use actual data, and then errors in that data collection are taken into account. So if the data is sparse, if it's noisy, that's all taken into account. And so to start us off with structural identifiability, a couple definitions. A parameter, PI, is globally or uniquely structurally identifiable if only a single value for PI results in the observed output. And so then from this, we get a model is globally structurally identifiable if every one of its parameters is also structurally identifiable. And so the method that we're going to use to determine this is the differential algebra approach developed by Aduli et al. And this identifies the global structural identifiability of nonlinear models. So we have a nonlinear model, so this is perfect for us. And so here is a little set of bullet points of the proof, not getting into too much detail. But essentially what this approach does is you determine this input-output relation. And so to do this, our goal before we do that is to minimize the number of variables used, because this will minimize the amount of data that we actually need to use. So if we can get rid of a couple cell types, that's good. Then we don't need data on that. And so what we do is we took this first equation, solved for t, put it into this equation. Now this equation is just based on C and M. And then we solved for M, put it into this equation, and rearranged. And now we have this long polynomial that's only based on C. And so the nice thing with this is what that means is if we can rearrange the coefficients and solve for different parameters, then by only using tumor data, we could theoretically identify all the parameters. And so what we do is each of those coefficients in the polynomial can theoretically be uniquely determined. And then using different manipulations, we solve for each of those parameters. We found that, in fact, all the parameters can be solved for. So what this means is the treatment-free model is globally structurally identifiable with respect to tumor cell count data. So theoretically, given enough data, we could identify all parameters. But this is not actually the case in reality. So with practical identifiability, we started with the Fisher information matrix. And the simplified FIM is F equals X transpose X, where X is the partial derivative of the output with respect to each of the parameters at the different data time points. And the reason for this structure is just because this helps us to determine which of these parameters and their influence on the output is linearly independent, because technically these different parameters can be having interactions with each other. And so then it could be hard to, given a data set, identify parameters that are interacting with each other. And so you might need to fix certain parameters just to identify one of those. And so what we find with this is that the rank of the FIM determines the number of practically identifiable parameters given your data. So when it's the rank of the FIM with respect to cancer cells, cancer cell data is 4, T cells is 5, MDSCs is 5. And so what that means is that at most 5 parameters can be uniquely identified with our cell population data. And so then what we wanted to do, well, at this point, technically, we have that 5 parameters can be identified, but this doesn't tell us at all which of those 5 parameters we can identify. And so what we wanted to do is to narrow down the search for these parameters. And so what we can use is sensitivity analysis. And the reason why we can use this is because this is actually woven into identifiability analysis, because sensitivity analysis, remember, it's when we shift a parameter, it's showing the influence that shifting that parameter has on the output. So this is the forward approach. Whereas identifiability analysis is this backward approach. So it's looking at the effect of when we vary the data, how does this affect the parameter estimates? And so what this means is that if a model is insensitive to a parameter, so if we shift a parameter a lot and it still generates roughly the same output, then that parameter will not be identifiable because that same output could scale back to a lot of different parameters. And so now going back to the sensitive parameters, we have these top 6 sensitive parameters, and we took that and then use that with profile likelihoods, which is the next method for practical identifiability. And so what we do here is these red dots, we fixed all the other parameters, just varying these parameters. These red dots were re-estimates of the parameters given the data using the gradient descent method. And then these curves, how these were determined, were we would shift a parameter off that estimate. So say, for instance, lambda C at 0.2, fix it at that value, and then re-estimate the other 5. And then from that, we generate an error value, and then that would help give us this curve. And so what this is showing is that you can clearly see in this graph that there is a single parameter, even when we move it along its specified range, that generates a minimal error. And then the red dashed line, that represents the 95% confidence interval. And so it is actually above the red dots here. And so you can see it better here in this graph. So the 95, where it connects to the curve, that produces an interval. And so we're 95% confident that the true parameter value is within that interval. So the smaller that interval is, the better the estimate. And so then,
Sorry, just
oh, yeah.
Oh, I don't know how long your computer lasts with that.
I'm just going to grab my charger real quick. My computer has battery issues. Spilled peach juice on it a few months ago. Ever since, it's gone downhill. Oh, wait. Thank you. So now to find the practically identifiable ones, those will have that distinct minima. And so, for instance, here the tumor carrying capacity does not have that. And so what this means is that these, so the tumor growth rate, the T cell kill rate, that has a distinct minima. Inhibition rate by PD-L1, PD-1, and by the MDSCs, and the MDSC death rate, those all have distinct minima, and so those can all be identified with the data, so they're perfect for treatment personalization. So now what we want to do is take those 5 identifiable parameters and create a virtual patient cohort. And so what we did is we uniformly sampled 10,000 patients from our parameter space of those identifiable parameters. And then each of those patients were given their own optimized, personalized treatment regimen. And then the patients were categorized according to survival outcomes post-treatment. So for survival analysis, it's typical to usually evaluate the 2-year and the 5-year survival outcomes for humans. But in our case scenario, we have mouse data. And so what we did is we compared, to have a comparable outcome, we compared the mouse lifespan to the human lifespan and found that 22 days is roughly 2 mouse years. And then 55 days is relates to 5 years. And so then taking those 2 different timeframes, we ran through these survival thresholds twice. So we have different thresholds for if a patient if they die after treatment, if they have progression-free survival, so the tumor isn't growing, but it's also not decreasing. And then we have disease-free survival, and then we have tumor recurrence otherwise. And so C of N represents the cancer cell count N days post-treatment conclusion. And so for the mortality threshold, we have if the tumor gets close enough to the tumor carrying capacity, the patient dies. And then for progression-free survival, C of TF is the tumor size at the very end of treatment. And so we have if the tumor later on is less than or equal to this, then we assume we have progression-free survival because it's not growing. Or if we have that the tumor is relatively stable, so for here we evaluated the last 10 days of the survival interval that we're looking at, and saw if it stayed relatively around the same point, then the patient had progression-free survival. And then for disease-free survival, if they had less than one tumor cell, they were disease-free. And then otherwise they had tumor recurrence. And so what we found is, here's a survival analysis. So this is similar to the ADC, similar in look to the ADC plots. So we have the parameters on one axis, same parameters, the 5 identifiable parameters on the other axis, and then scatter plots. And then these scatter plots are divided between those 4 different categories. And so, and then along the diagonal, we have different histograms for those different categories. And so what we find is for both the 2-year, so 22 days and 55 days, both of those different categories, we have for patients with a high tumor growth rate, a low T cell kill rate, as well as high inhibition rates by PD-L1, PD-1, and by the MDSCs, that those patients were more likely to die by the 2-year mark and the 5-year mark. So that completely makes sense. That's not actually too big of a conclusion, because what essentially that's saying is that these patients have very aggressive tumors, high growth rates. They're very immune suppressed and immune compromised, and so they're less able to deal with those highly aggressive tumors. And so they are more likely to die. But the main interesting takeaway from these results was actually with the MDSC death rate. So with this, the reason why, some background on why this is interesting is because this death rate gives us a longer term marker for survival. And so with glioblastoma in the last several decades, even though there have been improvements to the 2-year survival and the median survival, so shorter term survival, there hasn't really been hardly any improvements to the 5-year survival. And so what this is showing us is that at this 2-year mark, the MDSC death rate, a low MDSC death rate, is indicative of tumor recurrence. And then by the 5-year mark, it's a marker for death. And so this gives us just that longer term outlook on things. And so, and also not only that, but high MDSC death rate shows us is associated with disease-free survival. And so the reason why this would be the case is because the high MDSC death rate would mean that your own body is dealing with this form of immune suppression, and that these MDSCs are dying faster. They can only suppress your immune system for a short period of time, and so the patient is more likely to have disease-free survival. So the overall conclusions from this were that an optimized treatment regimen improves the survival of an average mouse from 32 to 111 days post-implantation. And then the treatment-free model is globally structurally identifiable. And so with that, all parameters can theoretically be determined given perfect data, so completely thorough and noise-free data. And then given our mouse data, we have 5 practically identifiable parameters. And so these are suitable for treatment personalization. And then for patients with high tumor growth rates and low T cell kill rates are more likely to die after treatment because they are more immune compromised with more aggressive tumors. And then lastly, the MDSC death rate is a useful predictor of long-term disease-free survival or death. And so with that, thank you for listening, and also thank you to my collaborators in the lab and at Arizona State, and then here at UF, Dr. Rong, and then my advisor, Tracy.
Any questions from the audience? Yeah, my computer's frozen. Can you click your chat?
Let's see. I don't have anything in the chat here.
So I think since a lot of people have, I've seen the similar talk, I think the questions might be sparse, but okay, well, yeah, I guess, and people can always reach out to you if they have questions. So let's end here, and thank you again so much for taking the time.